available now. So we'll go to the plenary session now.
Shall I start, sir? Good morning, respected teachers and colleagues. At the onset, let me thank the organizers for providing an excellent arrangements and for providing me with this opportunity. This talk will be little different from all the sessions for the next 3 days. In that, it will be more of a social aspect rather than an academic fest here. So the discussion predominantly will be from a health planning strategist rather than a nephrologist view here. And two, the problems which we will be facing is not universal for all nephrology patients here. It is unique to patients, to the lesser privileged patients, renal patients in Tamil Nadu. So we'll start here. So the health burden, most importantly, as we all know, RRT absorbs 5 to 7% of all total healthcare budgets. But the percentage of people who are affected is a minuscule comparing the general population. So the fund it erodes is enormous, but the number which is to be addressed is less. So the next most important thing which was little distressing is this. CKD is a major ongoing but silent epidemic. We know it is asymptomatic and the percentage was around 7 to 10%. In a recent study which was conducted throughout Tamil Nadu, over 10,000 people were taken as a cluster samples throughout Tamil Nadu. The incidence was alarming, it was 17%. And only 10% of ESRD patients receive the benefit of dialysis and the rest are left with the state-funded dialysis programs. So the state government has an extra duty to provide free dialysis for these patients. And the second most distressing thing regarding ESRD was the age group was between 30 to 60. Predominantly, the economically productive age group is affected and that provides more stress to the family. And the last one, which is the little more alarming, is 50% of all CKD patients do not come in the initial stages where they can be delayed, the progression can be delayed. They land to nephrologist in stage 5, 50%. So when they come in, they might need dialysis. To summarize, the GBD report says that CKD stands 5th among years of daily lost. It was around 19th, now it has progressed to 5th. And most importantly, it has increased from 3.1% from 1.1%. And the next point is majority, around 40% of all people with CKD in Tamil Nadu are below poverty line. And patients in the lowest income group are unfortunately younger. So this has some significant implications for a health planner strategist. A huge problem is ongoing, which will erode into the exchequer of the state government, but they have to provide free of cost. So they have to strike a delicate balance between their thing. So they have got two problems with them. One, to provide free treatment, costly treatment for patients. Two, to prevent retardation of CKD. These are the two issues which were put forth before the health planner strategist of Tamil Nadu. So what was done for the three replacement therapies which we know? I'll start with CAPD first. CAPD, as we all know, RRT in the developed countries, majority in any country is hemodialysis, approximately somewhere around 70 to 80%. CAPD in developed countries is around 14%. In our country is much lesser than this. So if we take this scenario here, overall ESRD patients across the globe, PD is not the first choice, apart from selected countries like Hong Kong, we all know here. So some parts, apart from Mexico, Hong Kong, all other countries, we know it is HT first comes in here. And this is the global utility of CAPD. We are less comparing the other countries in utility of CAPD. And this is from our study, which states that only 6% of all Indian patients are on CAPD. So total number of patients on CAPD in India is somewhere around 6,000. If it is HT, it will work out to somewhere around 1.5 to 2 lakhs. And CAPD, the one reason which we state why it is less utilized of these three reasons, most important among them is the cost factor. Cost factor is the most important deterrent for the extensive use of CAPD. So this is regarding the nephrological perspective. We all know this advantage of CAPD, but from a health planner strategist perspective, this was most important. CAPD is an excellent RRT modality for ESRD patients in developing world who live in remote villages with poor access to HT facilities. It is here the government should provide the treatment for people who cannot afford and who cannot have access to the hemodialysis centers. So CAPD became a priority for TN government. And one more thing we all know, it is environmentally responsible. The statement I got, it was a little heartening to see, it is environmentally responsible. And it was ideal during pandemic. So we got a procedure which has its own advantages, but it has got a lot of challenges to be enforced in the community. So challenges, to summarize: cost factor, technical glitches, and infection. Infections and technical glitches, nephrologists will take care, and the government will take care of the cost factor to provide this dialysis free of cost to the lesser privileged people. So in South African countries like India, most PD patients do not have healthcare insurances and have to pay from their monthly supply, monthly pocket, which will be difficult for most patients. So this is the same studies told that poor accessibility of remote villages to PD fluid supplies, especially across mountain terrains, remains a challenge. These are the points which were noted by the health planning strategist of TN. To negate these issues, they have come up with a solution. And cost analysis. Cost analysis regarding CAPD contrasts conflicting reports. Some countries, developed countries, claim PD is cheaper than hemodialysis. For example, if you take Canada, Australia, Netherlands, they say utilization of PD is higher and is propagated as a cheaper modality. So now, Hong Kong, where PD first policy, they also claim PD is cheaper than hemodialysis. What about Indian scenario? In Indian scenario, the latest study which is coming here, peritoneal dialysis first initiative in India, a cost-effective analysis. They have analyzed using two parameters regarding life years, LYs, and quality adjusted life years using a mathematical Markov model. They came with two important findings here. What was that? The QALYs life per kidney failure patient is significantly better in PD than hemodialysis. They claim, as for the patient's perspective, CAPD is better than hemodialysis. And they've given a statement, from a societal perspective, a PD first policy is cost saving as compared with the HT first policy. But they have recommended the consumable, which is currently around 220 rupees per bag, should be brought down to 70 per unit. And now, this is the discussion general, but what about the patient? For patient, striking differences, CAPD is around 3 times costlier than your hemodialysis. So for a patient perspective, he cannot, a patient living below the BPL line, not even the low middle class cannot use your CAPD. So now most governments, not only Tamil Nadu government, most governments address this policy. So state governments like of Tamil Nadu and Kerala do not levy any VAT on dialysis consumables. Dialysis is also covered free of cost under CMCHS in Tamil Nadu and Karunya scheme in Kerala. And there is a national dialysis policy across the country. So government is putting its extreme efforts to provide free of cost dialysis for all patients across the country, but still challenges are there. And most importantly, this challenge is not a single phase challenge. It is not only with the cost factor, it is not only with the nephrologist, it is with the primary care physicians also, who prefer hemodialysis rather than CAPD because they were not oriented towards CAPD in their UG curriculum. So the challenges in the community is multi-tier system. So the solution also should be robust. So with this, initially, the government of Tamil Nadu started to provide free of cost consumables, catheters, everything is free of cost for all patients, and the program went on. This was around 3-4 years back. So what are the challenges? The bags were provided free of cost. In spite of that, many patients with CAPD were non-compliant. They were not coming to the hospital on the stipulated day to collect the bags. So when we pondered into the problems, the thing which they told was, they have to collect the bags, which is around 90 bags, which works up to 180 kilograms. If it is 180 kilograms, to transport this, they need around 1,000 to 1,500. That is not a big deal for the esteemed audience here, but for a patient sitting in a remote village, that is a stiff money. So he has not, he became his own doctor. What he did was, instead of doing 3 sessions per day, he started using 1 bag per day. So 2 problems arose. One, either he came with uremic symptoms, or he came with acute pulmonary edema. So this was the problem with even though it was supplied free of cost, 2 problems. One, acute pulmonary edema or uremic encephalopathy, and we lost the thing. So this non-compliance was also referred to the health plan strategist of Tamil Nadu. So this was not enough. What was not enough? Supplying bags free of cost was not enough for COPD patients. So now the health planning strategists of Tamil Nadu wanted to address the issue of non-compliance. So they had 2 issues. One, to provide dialysis free of cost. 2, to retard the progression of CKD. To retard the progression of CKD, 2 things to be addressed. The 2 important diseases which contribute to the progression of CKD, namely diabetes and hypertension. So they wanted to stress to negate the non-compliance of these issues. Non-compliance, unfortunately, is universal. So WHO has come with 5 reasons for non-compliance. 1, patient-related. 2, condition-related. Lack of symptoms. This is where hypertension and diabetes comes in. Since they don't have any symptoms, they don't go for drugs. So then therapy-related, social-related, and health-related. So a systematic analysis of non-compliance was done by the health planning strategists of Tamil Nadu, and they went into the goal, which they had a goal was, they should decrease the premature mortality for non-communicable diseases by 1/3 before 2030. So they have to come up with a robust plan to achieve this goal. So the challenges which we had was, what was the complaints rate? Complaints rate, this was a study which was step survey done by the TNHSRP in 2020. Only 7% of hypertensives were under control, and only 10% of diabetes were under control. And we all know all pathies, nephropathy, neuropathy, gastropathy, cardiomyopathy, all pathies are because of this non-compliance here. If they are addressed better, we can delay the progression of your end-stage diseases. And as I told, non-compliance is universal. This was a study in Baghdad. They have claimed 2/3 of patients with hypertension and around 2/3 of patients with diabetes are non-compliant. So they should find a method to stick to at least promote this adherence and silent killers. This was a study done in 2021, medical adherence and blood pressure control, a scientific statement from American Heart Association. They have pondered the measures to increase compliance and negate non-compliance. They have given many strategies: patient education, pharmacist, motivational, and so on, a huge list. At the end of the study, they are told none of the strategy had a significant impact on the compliance. So whatever they have done so far was not enough to promote compliance. This was also analyzed by the health planning strategists of Tamil Nadu, and they came up with a solution. This solution was like biting a bullet. It was easier told rather than done. What is the solution? This was healthcare delivery at the doorsteps of people. To put it in a nutshell, if Moses doesn't come to the mountain, let the mountain go to Moses. So this was what was planned. This was a master plan by the NHM of Tamil Nadu. This was a master plan by this thing. And this is what now I'll say how it is being done here. When this was structured, this health planning strategist team had 2 important characteristics which are essential for any health plan strategist. Number 1, long-term vision. Number 2, compassion. Most importantly, if you look at the point here, hypertension and diabetes mellitus, this was a long-term vision. Here we know the current compliance is 10%. If somebody comes and gives the tablet at the home, I don't claim 100% compliance, but the compliance will increase by at least 10-20%. And that will not stop CKD, but that can delay the onset of need of hemodialysis by 5-10 years, which will be of enormous help for the individual, for the family, and for the society also. And the last two was the compassion regarding physiotherapy and palliative care. Imagine a patient sitting 50 kilometers from here in a village with hemiplegia, with a stroke. He has to come 2 to 3 times a week to a center in Coimbatore, travel. A hemiplegic patient cannot travel in a car, in a bus. He has to utilize a taxi. It causes enormous stress, and they won't do it, and they will be left to die. Similarly, palliative care. So here, a physiotherapist goes to the house, does it periodically. Palliative care nurse goes to the house and does dressings. The master stroke for nephrologists was inclusion of CAPD. So now currently, the bags are delivered at home to the remotest village in Tamil Nadu. And when they envisaged this plan, the first thing they made it sure was, it was not just a courier service. We are not just going there and delivering bags, but it is much more than that. So the modus operandi, how was this done? This was flagged by our Honorable CM on Tamil Nadu on September 5th, 2021. And the apex, it is by the MDT, NHM and PD, TNHS-RP. Those two are doing fantastic job. Whatever the nephrologist requests, it is immediately done. And then the state nodal officer for renal health is the senior most nephrologist in Tamil Nadu Government Service, Professor Dr. Gopal Krishnan sir. And under his instructions, it is being carried out methodically. And we have got 3 phases: induction phase, handing over phase, and follow-up phase. Induction, very easy, nephrologist in tertiary care centers. Handing over phase and follow-up phase is very crucial. What is it? How it is done? We have included one sect of nurse called as palliative care nurse. They were trained. They were trained for 3-4 days. They came to the hospitals. They were trained to do a cycle of CAPD, and they were told about the red flag signs, exit care site, and EP administration. So they were trained, and when we had the confidence that they can go to the house and do justice, they were left into the community. And now the handing over phase. Handing over phase, it is from the nephrologist to the DPO, to the physician, and to the nurse. The nurse was the final point who goes to the house and does everything. And in the home, what is done? It is not just providing bags. Once a week they visit, they check vitals, RBC is checked, they check everything regarding EPOs administered, and most importantly, CAPD waste bags are also disposed. It's a complete, robust plan by the NHM of Tamil Nadu. And now I'm very glad that even the remotest village in Tamil Nadu, a patient in a remotest village in Tamil Nadu will get bags free of cost in their home, including erythropoietin weekly, with perfect monitoring, and this is being done effectively for 1 year. And follow phase. If there's any problem in the house, the palliative care nurse will inform it will be reverse. It will go to the block medical officer, it will come to the nephrologist. So it's a close-knit circle, well organized, well channelized. And this is what is done. The house visits evidences. Home visit chart is there. It is a methodical chart is maintained. And this is absolutely free of cost. Not only for patients of Tamil Nadu, it is for the patients of India. Under this scheme, recently we had a patient who came from Andaman who underwent a CAPD, percutaneous CAPD, absolutely free of cost, and he's gone back with bags. And observations. So far, where we stand here. Approximately age profile is this, and we have got the distance is there. Scenario, we got expired patients were a little higher, maybe because CAPD is not used as the first modality, it comes later, so the mortality was a little higher. And coverage, we have covered literally all states, all diseases are covered. Most importantly, the key to success, it is ensured 100% compliance, early spotting, it's a holistic home care for CAPD patients. And evidence, 2019, only 16 patients were in government sector. 2020, it is around 40. Currently, 203 patients are receiving the bags at their home, perfect monitoring. And what is the mission? Healthcare, no one should die of ESRD. To put in a nutshell, to reach everyone, not to lose anyone. Hemodialysis is also under the purview. 1 minute, please. So, hemodialysis, what we do, the point here is Tamil Nadu government has got 128 dialysis centers, 2 centers of excellence, and this is first among the state. This is the first. This is the number one state having 128 dialysis centers. Karnataka has more numbers, but that includes a PPP, the so-called your private combination. But here it is absolutely government-centered. And disease donor in Tamil Nadu was 6 years consecutively number 1. Currently number 2. But most importantly, of late, a master stroke by the government of Tamil Nadu. They have made all Tamil Nadu medical colleges as NORTS, non-organ retrieval centers. And currently we had 5 organ harvested from a non-organ retrieval centers. So, to put it in a nutshell, coming to all modalities, what is the message we want to convey here? Patients in Tamil Nadu and India are in safe and secure hands of both nephrologists in the government and private sector. Thanks a lot.